Hi everyone, my name is Malini Sagar. I am a medical doctor and one of the authors of the study in brain communications on cerebral microbleeds after COVID-19 in the general population. To begin with, I want to mention that cerebral microbleeds are often found incidentally on susceptibility-weighted magnetic resonance images. They associate with arterial disease such as amyloid angiopathy as well as dementia and old age, and they indicate an increased risk of intracerebral hemorrhage, which occasionally can have therapeutic consequences, causing a restraint and consideration with regards to the use of blood thinners, for example, while treating stroke. On the other hand, COVID-19 is a highly transmissible pandemic disease which can cause lingering neurologic symptoms. A common denominator is that microbleeds have been described in many cohorts of critically ill COVID-19 patients. However, this poses the question of whether this also applies to COVID-19 patients in the general population. If we look closer at the COVID-19 cohorts that were critically ill, the microbleeds have in general been located differently than what we would expect in cases of amyloid angiopathy, for example, which indicates a different cause. The microbleeds could potentially be related to the treatment of critical illness, for example, being caused by anticoagulation or elevated central venous pressure due to mechanical ventilation. On the other hand, we have the endothelial hypothesis, i.e., where the microbleeds are caused by the infection itself, either mediated by cytokines or the ACE2 receptor. However, non-hospitalized patients with COVID-19 are underrepresented in the literature. So with this in mind, we used all available MRI scans performed in the capital region of Denmark between January 1st, 2019 to July 1st, 2021. The exposed cases in our study were identified based on a positive PCR test carried out before the scan and matched based on age, sex, and comorbidities with 3 patients each who had their MRI in 2019, i.e. before the pandemic. The number of microbleeds on susceptibility-weighted sequences was counted using an artificial intelligence algorithm. And for clinical insight and validation of the algorithm, we also screened radiology referrals and reports. All in all, our original cohort consisted of 7,155 patients, from which we recruited 73 exposed cases, matched with 219 pre-pandemic controls. We observed that 12% of cases, yet only 5% of controls, had minimum 5 microbleeds on their MRI, and that this significant difference persisted when we excluded patients with a high risk of microbleeds, such as those with dementia, as well as in the subgroup where we only analyzed our non-hospitalized patients. Looking closer at the referrals and reports from radiology, we first of all had excellent agreement between the AI algorithm and the radiologist's read. And we can also observe that the bulk of our patients were referred to MRI due to common indications such as suspected stroke. So to sum it all up, our study indicates that COVID-19 may increase the risk of incidental microbleeds on MRI, regardless of the severity of the viral illness itself. Also indicating a separate cause of the microbleeds other than, for example, amyloid angiopathy, old age, or hypertension. The occurrence among non-hospitalized COVID-19 patients points to an etiology unrelated to the treatment of critical illness and lend support to proposed viral mechanisms, such as endothelial activation via the ACE2 receptor. In addition, findings such as these could be considered during clinical decision-making, for example, prior to potential avoidance of blood thinners. With that said, and on behalf of all of us involved, I would like to thank you all for tuning in, and please do not hesitate to reach out if you have any comments or questions. Thank you for listening.